Hi, I'm Dr. Jared Gardner, and I'm here today with my awesome residents and fellows, and we are going to look at some paniculitis cases. So, paniculitis is inflammation or damage of the subcutaneous fat. All right, who wants to take the first case?
I can take this one.
Okay.
So we're looking at a punch biopsy, and then you can see a cellular infiltrate in the deeper dermis, and then it looks like inflammation of the fat lobules. And the fat lobules have a little bit of like a bluish hue to them, and some necrosis that looks like saponification.
Mm.
I feel like it kind of looks like garlic in cross section. So this is
Oh,
the
I like that.
yeah, that's what it reminds me of. But it looks like pancreatic paniculitis.
Yeah, it's this very distinct pattern. Fat necrosis can have a variety of different patterns, right? And the usual one we see is little, foamy histiocyte xanthomatous cells, and then the fat cells shrinking down to various small sizes, with a little mixed inflammation. But this is different, right? This is like wiped out, dead. You can see the ghost outline of the fat cells, but it's more grungy, more dirty, more fibrillary. It's got this pink, smudgy stuff, which turns into blue and purple in areas. And exactly like you said, that's called saponification. That is the fat undergoes necrosis, and then it combines with calcium, and it basically makes like soap. Like in the old days, soap was made by like melting down, tallow or lard, like animal fat, right, and mixing it with lye, I think sodium hydroxide. But so this is a similar kind of process where you're taking like a mineral salt and mixing it with lipid, and it makes this kind of soapy like substance. And in fact, you can actually see this. It has like a whitish yellow, firm kind of look in fat that has been exposed, that has this type of change. And so, like you said, this is pancreatic paniculitis. So the idea here is that a person has pancreatitis or maybe a pancreatic tumor, something that's causing pancreatic lipase enzyme to spill out of the normal place it should be, which is in the tubules and ducts going to the GI tract to help dissolve, fatty meals. And instead, it gets into the bloodstream, and that the high levels of lipase basically get into the subcutis and dissolve and necrose the adipose tissue by breaking down the lipid. And then it secondarily gets calcification, giving this saponification pattern of fat. And it often has a lot of inflammation with it too. Or I'm sorry, excuse me. It sometimes may have inflammation with it too. All right. And if there's a lot of neutrophilic inflammation and this kind of pattern, I believe alpha-1 antitrypsin paniculitis, which is something I don't think I've ever actually diagnosed in real life. It can have some similarity to this, but my understanding, if I recall correctly, is that it usually has more neutrophilic infiltrate. Does anyone know more about that than me, or know if that's right? I meant to look that up and I didn't. All right. So anyway, pancreatic paniculitis. Kind of cool, and interesting fact is I've occasionally seen, this is relatively rare actually, at least in my practice. I've only seen a couple examples, I think. But I have seen this same pattern a few other times, and that were not in the skin. One, or well, not exactly. One was a person who had multiple kind of calcified masses in the bilateral buttocks, and they were like in the subcutis, but like kind of large masses. So when they were taken out, I had the impression getting the case that they were like removed as like that they were thought to be tumors. But in fact, the surgeon knew that from imaging that these were calcifications, but microscopically, they were not just regular calcifications like you'd see in, say, calcinosis cutis or tumoral calcinosis. They had this saponified pattern. So I thought, why is this? This is strange to have this pattern just randomly. And then I looked up, and the patient had a history of pancreatitis a couple of years prior to the case. And so my theory is that the patient got pancreatic paniculitis there while they had active pancreatitis, and then after it resolved, it kind of got walled off and turned almost like what you see like encapsulated fat necrosis look like, but it had the saponified pattern in it, and they had a history of pancreatitis. And I've seen it also like in the omentum around the GI tract. Same thing, had this unusual pattern. A GI path colleague showed me, and turns out the patient had pancreatitis a while ago in the past. So even a kind of distant pancreatitis can leave this kind of pattern of fat necrosis around for quite some time, especially if it gets walled off and not, cleaned up by the body. So, and then here's some more like a little more typical like foamy cell histiocytes like we see in regular fat necrosis. So pancreatic paniculitis. Great. Let's see next case. Okay. Who wants case 2?
This one, kind of a square punch there on the left. The other one looks like it might have been pinched just a bit.
Mm-hmm.
It looks, almost like morphea-like just because of how
Yeah,
squared off it is.
that's a good point. It does.
But then there's a lot of inflammation, especially like perivascular, periagnexal, even maybe a little interface at the very top. It doesn't look like a lot of change actually in the epidermis.
Yeah, like you said, just some kind of subtle vacuolar interface, right? Some vacuoles and rare apoptotic keratinocytes. Once it comes into focus there, a little bit of a rattiness or torn, tattered look to the basement membrane, which I find helpful to when I'm looking for a subtle interface dermatitis. Even if I don't see dying keratinocytes here, which to me is like the thing I really want to see as like the gold standard. But there are a lot of vacuoles and there's this like really ratty appearance, as opposed to the kind of more, say, more clean, like sharp line of demarcation between the dermis and epidermis here, right? This is basically normal-ish, and then over here we've got pretty decent vacuolar interface with pigment incontinence, which is another sign that we probably had interface, and there's like one dead keratinocyte there. Okay, sorry, carry on.
No, it's perfect. So like with these changes, you're already kind of thinking, especially with like the superficial and deep inflammation, like, oh, is this some sort of connective tissue?
Yep.
You can tell that the fat is like being replaced by like this hyalinized material, and so I think all these things kind of fit together for like with this profunda.
Yeah, very good. Yeah, this is lupus profundus, or deep lupus, also known as lupus paniculitis. I think some people like to split that out because, it's Dermpath, we got to split. And if I recall correctly, like some people will use lupus paniculitis when only the fat's involved, and lupus profundus when there's dermal and epidermal changes of lupus, as well as lupus paniculitis. I don't care. I think they're basically the same thing. So, in any case, sorry if anyone out there is listening and wrote a paper about this. I didn't mean to offend, but that's I remember hearing that before. Yes, so sometimes the reason of bringing that up though is that sometimes you get lucky and you get a case like this where you've got slam dunk features of lupus erythematosus in the epidermis and dermis. So interface alteration in the epidermis, superficial and deep perivascular lymphocytic infiltrate, often with plasma cells, perieccrine and maybe perifollicular lymphocytic infiltrate. You may have increased mucin, all the stuff you see in lupus. And then in addition to that, you get the paniculitis component. And so I think lupus paniculitis is really interesting because it gives you this very distinct appearance of the fat. So the fat cells are dead. Well, how do we know they're dead? They kind of look normal-ish, not exactly. One thing that's weird is that, normally fat cells are uniform in their size and shape, more or less. And here we have like big ones, small ones, medium ones. That's generally a sign something's abnormal with the fat, right? When the adipocytes are of varying size, it's a sign to at least look closer to figure out why. So the other thing is when we look here, you know what we're missing? We have a couple inflammatory cells, but there's no adipocyte nuclei, right? So that's generally a clue for necrosis. Sometimes there's a bunch of inflammation, but sometimes you get areas of necrotic fat or other things that are devoid of inflammation or have minimal inflammation. And they are the clue to necrosis, is the paucity of normal nuclei of the cell type you're looking at. So in this case, the adipocytes, they're too pink, right? And in addition to them being dead, like you said, they're hyalinized, right? They have this weird mixture of like dense fibrin / necrosis, fibrinoid necrosis, filling the spaces in between the dead adipocytes. And then additionally, you often begin to get really dense sclerosis of collagen. And like you said, it gives it that kind of firm, squared off sign that makes it look like a sharp kind of square or rectangle shape. That makes you think a little of morphea, right? In this case, part of this probably looks like morphea because it's probably on the trunk, and I feel like lupus profundus or lupus paniculitis is more common on the trunk, to my recollection. Does someone Anyone read about this more recently? I feel like in my mind I think of it on the trunk, but maybe I'm confusing it with tumid lupus, which is usually on like the chest or upper arms,
Yeah, it's usually like upper extremities,
upper extremities. Cool,
trunk area, like upper trunk.
excellent. So kind of similar distribution to tumid lupus then. Cool. Which tumid lupus, which will clinically look like kind of firm, indurated, pink or erythematous uh, nodules or plaques. But microscopically, tumid lupus will just show you this dermal stuff. Basically, it looks like lupus in the dermis, but without the epidermal stuff and without the paniculitis stuff. So, and tumid lupus generally not associated with lupus erythematosus systemically. What about lupus paniculitis? Do any of you know about the? Clearly, I should have read more, huh? Do any of you know about the association of lupus paniculitis with systemic lupus, like what frequency it's associated? Well, I'll have to do more reading on that because I can't remember how often.
Dr. Gardner,
Yes.
I quickly Googled. I won't say that I knew this.
Oh,
But it
I
looks
love
like
your honesty. Bonus point. I have to look stuff up every day.
I Googled it. But it's 2 to 5% of lupus cases get lupus paniculitis, so pretty low.
So low number that get the paniculitis. I wonder though what percentage of the paniculitis patients have like SLE, like systemic involvement. I wonder. Interesting. So, because some things like you know have a high association one way, but low association the other way. Of course, you guys know that, but I remember sometimes finding that tricky as I was learning cases and diseases. But I find that fibrinoid necrosis pattern of the fat really interesting and pretty distinct for this. Then you have foamy histiocytes, xanthomatous cells, typical fat necrosis stuff, plus a lot of lymphocytes and oftentimes plasma cells. And many these lymphocytes will be a mixture of B and T cells, but oftentimes in lupus there is a more abundant component of B cells. Sometimes they can even form germinal centers, like follicles with the germinal center inside. So lymphoid follicles. I don't think we see that in this case, but that's a good thing to know about. And what's the other thing that could kind of be a potential mimic of this fat pattern? We might be seeing almost a little tiny.
The subcutaneous T cell like paniculitis T cell like.
Yeah, good. Subcutaneous paniculitis like T cell lymphoma or paniculitic T cell lymphoma, or also known as alpha beta lymphoma. And we'll talk a little bit more about that later, but it can sometimes have very closely overlapping features with lupus paniculitis. And interestingly, some of those patients reportedly also have lupus erythematosus. And so there's maybe some debate in the literature that some cases may have been misclassified one way or the other, but there does appear to be some patients with bona fide subcutaneous paniculitis like T cell lymphoma, alpha beta T cell lymphoma that also have lupus. So there is this kind of complicated overlap, and I will, when we get to that at the end, I will talk about that and read you a little excerpt from a book that I like about some tips for telling that apart. Okay. Oh, one of my favorites. What is this? This is so fun.
I can take this one. It's you can see that there's like adipose tissue here, but it's really small. It almost looks like, at least to me, like it's hypercellular because it's darker than you would expect.
Absolutely.
So this is lipoatrophy.
Very good. Lipoatrophy or fat atrophy. And this is a like very extreme example. I see this pretty commonly in much more subtle, nuanced amounts on a pretty regular basis. To see it like this is uncommon. But I like what you said that there's fat there. Once you realize it's fat, at first glance, you might not realize that this stuff is fat, right? It doesn't look like normal fat at all, and it's way more cellular. But when you go closer, you're like, what are all these little round vacuoles? They look like little tiny baby fat cells. If you're having a really bad day, you could potentially think that some of these little round cells look like signet ring cells, like you can see in some forms of adenocarcinoma, like gastric signet ring cell, gastric adenocarcinoma, or other places in the body can produce signet ring morphology. to their adenocarcinoma. So I know here, like this looks like fat, but I think you can see how like some of these, and they almost look like they're making infiltrative single file cords and chains, like some carcinomas grow. I've certainly seen cases that really could cause confusion and mimicry of a signet ring adenocarcinoma, which is something that probably you don't probably see very much in Dermpath. I know I don't see it in Dermpath, and it's probably not in a lot of study sets, but for pathologists, I think it's a really important pitfall to know about, that those cells are not carcinoma. Easy to sort this out. Just do a keratin. Keratin will be negative here, okay? But the other thing from lower power, Nick, like you said, the really helpful thing here is the fat. It looks cellular, but you can still see that it's in lobules, right? There's one lobule, two lobules. Here's another lobule. So remember, normal subcutaneous fat or fat anywhere is arranged in lobules that have like delicate fibrous septa in between and kind of the bigger vessels in the septa. And then as you get out into the middle of the lobules, you have little tiny vessels. These little tiny vessels, look how many. There's tons of little tiny vessels. In fact, for anyone who has seen a myxoid liposarcoma before, the little tiny chicken wire vessels of myxoid liposarcoma, which is vanishingly rare in the skin, is usually in deep soft tissue, so kind of outside the scope of what we're talking about. But the vessels in that tumor look a lot like these vessels, and that's because that tumor is recapitulating embryonic fat, and these kind of vessels are always present in fat. The reason you can see them here is because as the fat cells shrink and the lipid gets used up and goes away, the cells get smaller, which means the nuclei that are always there get closer together and more dense. There are more nuclei in a given area of space on the slide. Same thing with the vessels. The vessels that are always there to transport lipid in and out of the adipocytes for fat storage and fat release when we need it for energy, right? That's why the fat is very richly vascularized, but they're really tiny vessels, right? So those vessels, though, as the fat cells shrink, more and more of the vessels get closer together and you can see more of them. So fat always has this amount of vascularity and cellularity. It's just way more, or I guess let me say, these cells are always there in fat. They're just all closer together when there's not all that big white space pushing them apart. So that's what results in this unusual appearance. The reason that's important is because, like I said, it could mimic carcinoma. It could mimic a liposarcoma if you're having a bad day. It could just cause you confusion as to what the heck is going on here. So why does lipoatrophy happen? What are some causes of lipoatrophy, fat atrophy?
Steroid injections.
Yeah, definitely. If you inject steroid too deep, too much, too strong down into the subcutaneous, it can certainly shrink and atrophy the fat. That's true. Anything else? Look at this artery in the meantime with that nice internal elastic lamina. I just noticed it and I thought it was pretty. And hey, while I'm gonna show you something. Can you guys see this funny, weird, like geometric pattern in the background, or am I like hallucinating that? Maybe it doesn't come through because it's too small. Okay, maybe it's hallucination also. I'm not sure. I got a new computer, and now when I zoom in real high power, I can see this like meshwork of geometric lines that are like weird pixels that I assume is something with the way my graphics card is displaying this. But it's so bizarre because I'd never seen that before. And then I saw it and I thought, oh, it's a weird scan. Then every slide looked that way, and I was like, it must be something with the way my new computer is displaying. I just have never noticed that before. I promise it's real. You guys can come to my office and see in person. But anyway, sorry for the diversion. I just noticed it again and I thought it was wild. Okay, so other lipoatrophy things. So yeah, definitely steroid injection, trauma, right? Pressure from an adjacent mass. I see fat atrophy and muscle atrophy sometimes next to tumors, like big soft tissue tumors that push and compress the fat. You can also get it from starvation or severe malnutrition, right? And those cases are really impressive, but thankfully we don't see them as often. But basically, the body just uses up all the fat and the cells are just like left as little husks, without their lipid inside. I don't know what the story was in this case as to why the atrophy happened, but a pretty good impressive example. And particularly like for pathologists watching in the GI tract, if you see this in like the omentum or some of the fat around the GI tract, it certainly can really make you think more of like a signet ring carcinoma. So don't be afraid to use a keratin if you got any doubt. And there are a variety of like lipoatrophy syndromes and diseases, all of which I found really boring and hard. Not that they're not important diseases, but really hard to read about and when I was in training because they're like no special pathology findings. They're just all, yes, there's atrophic fat, but they all have like hemiatrophy or other, I don't even remember the names. There's so many of them. In advanced AIDS, I think you can get lipoatrophy. So all sorts of different things. But anyway, this pattern can be applied across that. And oftentimes too, I will see some degree of fat atrophy in association with fat necrosis. Okay, so in traumatic fat necrosis or lipodermatic sclerosis, oftentimes you will have some atrophic fat mixed in with the necrotic fat. Cool. Oh, and one more vessel, cute little incidental finding. Look at that. This is a little, probably thin-walled vein, although maybe it could be a lymphatic. I cannot reliably tell them apart. But either way, it's a valve. See? You can't, like, sometimes you can perfectly see the opening between the two leaflets, but that's a valve either in a small venule or lymphatic channel. It actually does look like a lymphatic there, but I thought for sure that I knew something was lymphatic or not before, and then stained it with D240, and I found that my ability to predict it reliably is not super high. So even though I'm a soft tissue pathologist too that has interest in vessels, I can't always tell lymphatics from tiny veins. Okay, questions? Next case then. 4.
I can take this one.
Okay.
So pretty big piece of tissue here, and then I can see the fat with a lot of inflammation around it.
Yeah.
And then I think just coming into focus, I can begin to see some crystallization.
Right, that's the weird thing here, is at low power, it just looks like fat necrosis with a bunch of mixed inflammation. But then closer, what is this?
So the only thing I know that with the crystallization like this is subcutaneous fat necrosis in the newborn.
Good.
Maybe, I can't remember if you can see Scleroderma neonatorum either.
I can't remember, and I had looked that up for a recent lecture I had given that had that in there. And I think you may be able to have some of this crystals, but my understanding is Scleroderma neonatorum has like less actual necrosis, is more like sclerotic. And really the difference is like clinically they get these like woody, firm, spreading, indurated areas. And obviously those babies are sick and sometimes do not do well, and it can be fatal. Whereas this is subcutaneous fat necrosis of the newborn, which is like more histiocyte rich, more of these crystals. Clinically, what's the clinical presentation of subcutaneous fat necrosis of the newborn?
Term infant, maybe a stressful birth or something like that. And I think can present a little bit after the birth as well.
Yeah, and then it can be like in the kind of fattier, thicker areas. I think you can see it on the cheeks sometimes. Although if you see on the cheeks in kids, you also can think about cold paniculitis or popsicle paniculitis, which in young kids can cause kind of some similarities in pattern to this. But I think also, if I recall, in the trunks, like the trunk, the buttocks, in babies, there's a lot of fatty areas. But yes, this does mix these nodules that get kind of red or even violaceous. I think it can be bilateral and symmetric sometimes, and then will regress and resolve on its own, usually over a period of weeks to months, to my recollection. Again, I plan to brush up on this a little bit more, and then I woke up late, so I apologize, guys, for not bringing my A game today. But yeah, I think the crystals, these little spike cleft shaped, cleared out crystalline spaces. The idea is that these are, what kind of crystals do we think that these are? So,
are they triglycerides?
Yeah, I believe so. They are lipids that crystallize out, and my understanding is that they are thought to be triglycerides or fatty acids. And I brushed up on this last time I did a session that had one of these entities in it, and then I'm blanking on the exact which way it is. If it's that my recollection is that young babies have a higher concentration of either maybe it's of saturated long chain fatty acids in their triglycerides, and so it tends to be easier for it to crystallize out at lower temperatures, and then it makes these kind of spike like crystalline structures, and then during processing it dissolves and it just leaves behind the kind of ghost outline of where the little lipidized crystals were. That is my vague recollection. it may be wrong. So go, if you're online, or you guys too, go look it up, read up about it, make sure that, hold me accountable. And we can see if maybe next time I'll remember it correctly. But yeah, the point is that it happens, though, interestingly, in young babies only, where you get this pattern really. And I don't think I've ever really seen this in older kids or adults. And so that's the thought, is that it's because of the different fatty acid content that are in baby fat versus older people fat. And I have seen this pattern, though, in a baby in a different situation. And I think also in a couple of other cases that people show me pictures of. But one case of mine, and I've got an example of it on Kiko. I'll try to remember to put the link down below, but you can go to Kiko and look up angioinvasive fungus. And I have one of the most horrible and dramatic, terrible cases of angioinvasive fungus I had seen, but it was in a baby, and they had like an immune compromised situation, and they got a variety of, like it had, like, I think if I recall, aspergillus and rhizopus, both types of fungus invading the vessels, necrosing out the tissue. But in the necrotic fat, this pattern of radial spike-like cleared out crystals with that pink frilly background was there in the fat. So even though it wasn't subcutaneous panniculitis of the newborn or fat necrosis of the newborn, it was that same pattern of fat necrosis with the spike-like radial crystals and clefts. So they look a little bit similar to cholesterol crystals, but cholesterol crystals are usually bigger than this, and they're more like parallel in stacks, whereas these are more like kind of going out in a radial spokes. But just know that you can also see it in the setting of other types of fat necrosis in young babies. But yeah, this is the textbook example, though, of subcutaneous fat necrosis of the newborn. Kind of cool appearance. And yeah, for your testing purposes, remember to look up and learn about scleroderma neonatorium. I've never seen a case. My understanding is it's very rare, but it's very bad. And again, from the very limited pictures I've seen, microscopically, it doesn't look super exciting to my recollection. It's more of the clinical is really important in deciding that something's scleroderma neonatorium, which is different than this. And here, look, we almost have a little bit of arabesque pattern like you see in lipodermatosclerosis. So you can see that pattern, that arabesque pattern. This is not exactly like it, but it reminds me of it. You can see similar pattern to arabesque or membranous lipoatrophy change in other diseases, not just lipodermatosclerosis. We'll talk about that later. All right, this is case 5. What is this beauty?
I guess I can take this. This, I think, is like the quintessential gimme for panniculitis kind of things, or fatty tumor kind of things. So these are fat cells that we don't usually see in adults, and they kind of look like mulberries. And so this is just like a great gimme for a hibernoma.
Yeah, very good. This is a hibernoma, a benign neoplasm of brown fat. So it's not a panniculitis at all. Of course, it's here as a potential distractor to try to trick you, but it is brown fat. And so basically normal, regular brown fat, which is usually more common in younger kids. But rarely we can see a little bit in adults, but usually more in the deeper soft tissues, not in the subcutis. So like it's more common like around the neck. Sometimes you can see it around the kidneys. But so I occasionally see little wisps of brown fat in adults, but like you said, it is much more common in kids. But this tumor is a neoplasm of brown fat. It actually usually does occur in adults. In young adults, the most common kind of presentation. And it's I think a little unfair that it's a thing that's taught to dermatologists, because I have personally never seen a case in the skin. I think I've seen one or two that were subcutaneous. But still, they usually are like when they present their larger, deeper masses. I have never seen a hibernoma removed by a dermatologist, to my recollection. Always come out from surgeons. It's usually because they're either big or they're deep. At least that's been my experience. So maybe with enough time I'll see one. But in any case, it's so beautiful that, like, why not teach about it? Because it's so pretty. It's definitely one of my favorite prettiest tumors, and it's benign and beautiful. So we have a combo of 3 different types of fat cells in brown fat and in Hibernomas, okay? So there's a mixture of regular old white fat, the adult type of fat, these big white ones that look just like regular fat cells, and then the bubbly, multivacuolated mulberry cells, the cells that look really similar to lipoblasts, right? The only reason this is not like a pleomorphic lipoblast is because the nucleus is really uniform. It's not ugly and pleomorphic. But in some forms of liposarcoma, you can occasionally see lipoblasts that look like this. So the key here is that the overall pattern is brown fat. All the nuclei look just alike. And again, this scan doesn't have a great high power, but the nuclei of brown fat, they're like large, kind of large and very round and have a big central nucleolus. And then, so they might look a little atypical compared to, say, a normal white fat cell, which has a more thin, flattened, spindled or plate-like nucleus. These are like big round guys with a big eyeball of nucleolus staring back up at you, but all of the nuclei look just alike. So it's if you have never stared closely at the Hibernoma nucleus, I've seen people look at these and get worried by that. But once you look at them, all Hibernomas look like this. This is just normal, and normal brown fat looks like this. So then the third cell type, so I said there's white fat, the bubbly multivacuolated, little white vacuoles that often indent and compress the nucleus or scallop into the nucleus, just like how in cebocytes we get that. We get that same thing here because these are lipid-filled vacuoles, right? And the body is a water-based, right? Where we are basically an aqueous solution. So what happens when you put oil in water? It has to make a little spherule because it can't mix with the water. So the same thing, that's why we get these perfectly round vacuoles, and they push the nucleus out of the way because the nucleus has got water content. The vacuoles are made of lipid. The reason to belabor all that is when you see clear, sharply circumscribed vacuoles, that's a clue that they're probably really lipid-based vacuoles, like a bubbly mulberry cell, or in a sarcoma, like a lipoblast, or in a epithelial tumor. If you see that in the skin, maybe these are adipocytes, maybe it's an adipocytic neoplasm. So that pattern of clear vacuoles bumping into the nucleus is useful to say this is probably a lipid vacuole, and you can apply that across multiple things. Even when they're tiny little lipid vacuoles, like a foam cell or a xanthomatous cell, same thing. If you go really, really close, you can see those tiny little lipid vacuoles, sometimes bumping in and scalloping and denting the nucleus. All right, so finally back to I've gone off on multiple tangents. White fat, bubbly mulberry cells, and then the red cells, the red, pink, grainy, granular cells, which may or may not have some vacuoles. These cells, and again, you can't see it on this scan, the texture, they have a very granular, stippled, speckled appearance that gives them this reddish, grainy look. And those cells have that red, grainy look because they're filled with what type of cellular organelle? Anyone know? They are full of mitochondria, and that's because brown fat's function basically is to make heat, right? Like that's like hibernoma, like in hibernating animals, like bears, they have a lot of brown fat, makes heat, keeps them warm in the winter. That's the basic story of what brown fat's supposed to do. I think it has much more limited importance for us as humans, but in any case. Maybe we don't know. Maybe there's more mysteries to unlock. I know some people are researching brown fat for like weight loss and things like that. And in any case, the granular pink appearance is because there are a lot of mitochondria here. Okay, so those three cell types can be present in varying proportions in a hibernoma. Some hibernomas look almost just like a lipoma, with only a little bit of the mulberry cells and the reddish granular cells sprinkled in there. And then some are like loaded with the red grainy cells and loaded with the bubbly cells. Of course, these are the pretty ones that we like to put in study sets and on tests because they're way more beautiful. But I honestly see more kind of white fat predominant hibernomas in practice because I think that they just don't get put in study sets because they're more boring. They're prettier when they look like this. And oh, look at how many. There's a bajillion little capillary-sized vessels, just like in the fat lipoatrophy, just like in a lipoma with fat necrosis. The little vessels are there between every fat cell. They are capillaries, and so we're seeing those are just really dilated here. And then this particular case was down deep in the muscle, which is where I usually see hibernomas. And again, they're usually in young adults. They can be kind of large sometimes, 8, 10, 12 centimeters, even more. And if you get an MRI, they look like fat signal, but they look denser than fat signal. So they'll have areas that look similar to fat, but other areas that are clearly more cellular, more water content, not lipid content. If you're a radiologist listening and I'm misexplaining the wonders of MRI, I'm sorry. It is very complicated, I think. The reason I bring that up is that this is a tumor that is on imaging a potential mimic of liposarcoma, because radiologists will see this is a big fatty tumor in the deep soft tissue, and it's got areas that do not look like normal fat. So that always concerns you that maybe it is a liposarc. But the other thing to keep in mind is that an unusual looking fatty tumor on imaging could be liposarcoma, but it also could be hibernoma. And look at the beautiful striations in the skeletal muscle there. Oh, if you don't like that, I can't make you happy. It's just so cool to see something so symmetric inside, an organic structure. All right. I think you can tell I like hibernomas a lot. Benign and beautiful. Okay, 6.
I can do this one.
Okay.
This is something I feel like we get consulted for a lot.
Yeah.
But, this one, looking in kind of the deep fat is where you get most of the answers. Overlying it, you can see some like necrosis and like maybe some signs of like ischemia. But what you're really looking for,
You're right.
So like,
I like that. That's a really important point, because sometimes if you don't have the fat, this should be a clue. Maybe we need to look deeper here, right? The epidermis, you can barely even tell it's epidermis, right? It's like you can see the ghost shape of it, but it's all pink/red. All the nuclei are washed out, dead, totally dead. And yes, like you said, that's ischemic necrosis. That tells you acute ischemia, something bad is happening to the skin, is all dying and bleeding too. So what were you saying about the subcutis? Sorry.
Yep. So you see that, you go down and like, what's causing that? So looking in it, you're really looking for like the small vessels and looking for calcium in it and calcification. So you'll feel, kind of like the purpley color.
Very good. So what is this then?
So this is calciphylaxis.
Calciphylaxis, very good. So calciphylaxis is a complicated disease, and it can be kind of challenging to diagnose, because I think the question that comes up a lot is, this is, as you guys know, this is a disease that is a horrible disease that is very morbid and often fatal in a significant number of patients, and is very difficult to treat by my understanding, and is in patients usually with end-stage renal disease, chronic kidney failure. And it, particularly in patients that have a high BUN, is one of the thoughts, is that the high uremic level is part of what drives this process, and also the abnormal secondary hyperparathyroidism that you get from having long-term end-stage renal disease plays a role in this too. It seems like again is a pretty complicated, I think, physiology of this disease, or pathophysiology of this disease. But in any case, that derangement, the uremic state, the altered calcium and phosphate metabolism, and what happens is it drives calcium to be deposited throughout the body, particularly around vessels, including small little vessels. And that over time somehow causes the vessels to not flow well and to thrombose. At least that's, I guess, what's happening, because usually we see not only calcification around the vessels, but we often see fibrin thrombi filling up the vessels. In the ideal situation, you want to see calcs around tiny vessels. The smaller the vessel, the better, and the more helpful the finding is to me. We see calcs in the walls of arteries all the time, right? We can see it in atherosclerotic plaque in older people, and also in the media of muscular vessels, like arteries. We see something called Monkeyberg's medial calcific stenosis, which is either a cause or effect of hypertension. We're not really sure. The plaque probably plays some relationship, either causative or resultant from hypertension. So calcs in bigger vessels don't necessarily mean anything. But when we see calcs around little tiny capillaries, that is a phenomena I don't usually see except in calciphylaxis. So the reason I bring this up is because this is such a serious disease, and because we can incidentally see calcifications in a variety of settings. You want to be really sure that you're right about this. And so I find that it's often hard, and different people have different thresholds for what they're willing to consider enough to call calciphylaxis. So I'll tell you my way of doing it. I do feel like I probably am a little bit more aggressive about diagnosing calciphylaxis than some people. I don't know if I'm right or not. I've just noticed that my threshold is lower for making the diagnosis. And I also put a ton of weight on the clinical scenario. There are cases reported of non-uremic calciphylaxis in patients without renal failure. But I am really cautious to make that diagnosis, and usually I won't make it outright. I'll usually suggest it. But I have seen a couple cases that I thought were pretty convincing that the patient had. So how does this present? This presents usually with firm indurated, very painful areas in the fatty areas of the body. So often on the hips, the buttocks, the abdomen, the trunk, the fatty, thicker fat areas. But I also have seen a variety of cases that I thought fit really well for calciphylaxis on the lower leg. It's harder on the lower leg because we often see nonspecific calcifications in the fat, in the dermis, etc. So again, I ideally am looking for a patient that has high BUN and creatinine, and often has chronic renal failure, has very painful, often has pain out of proportion to examination, plaques. They begin to eventually break down and turn into black eschars that open up and get necrotic, may drain out, necrotic material, even bad stuff. And it can be horribly disfiguring and very, very painful. And then microscopically, I like to see calcifications around small vessels is the best thing. Some cases I see where I don't have that. I have other calcifications there, either fine granular calcifications in the dead fat or dead or dying fat, like here. See, we're seeing some frothy, bubbly xanthomatous cells, and then we're beginning to see calcium get deposited on that, little tiny speckles of calcium. The calcium sometimes can be chunky like this, but sometimes it's super fine. So this is one of the times I find a von Casa stain, which stands for calcium phosphate, this form of calcium. And it will turn it like from this purple color to like a blackish, a black kind of color, black/brown color. So it can help make it stand out. Also, when you got a lot of necrosis, sometimes there's nuclear debris and it's hard to tell, are these specks of dead, broken down karyorectic debris, are they just nuclear fragments or are they calcs? Sometimes also you get secondary bacterial infection superimposed, especially if you get a big necrotic eschar ulcer. You can get a bunch of infectious bacteria in there, like growing on the dying tissue. And I find bacteria and calcs, I think, can actually closely mimic each other. So sometimes a Gram stain and a von Casa can be helpful. So those are some tips for real life. But I want to see fat necrosis. I would like to see calcs around tiny little vessels. Sometimes it'll make like a little tiny circle around the vessel, like here. Oh, that's perfect right there. And then you will see calcs sometimes around bigger vessels. Sometimes the vessels that are a little bit larger will dilate and get calcs around the walls. Sometimes they'll make like a little donut. There was one over here that had that, like, oh, right here. This pattern, though, occasionally you can see in atherosclerosis or monkeybergs. So be cautious. You just see a donut of calcification in a incidental basal cell carcinoma excision. That probably is just incidental monkeyberg's calcific stenosis and not calciphylaxis. So again, the clinical is really crucial for this disease. And I really depend heavily on my dermatologist and also the nephrologist and their input and thoughts about whether something's likely to be calciphylaxis. And if I'm not sure, I'll be descriptive and say I'm concerned, or I think, to me also, if I get big eschars in a patient with end-stage renal disease and I see acute ischemia and necrosis and some calcifications, even if I don't see it in the vessels, to me, that's calciphylaxis until you can prove to me it's something else. Because what else is causing it, right? So that's kind of the approach that I take from a philosophical viewpoint, is that you've got this setup where the person has renal failure, maybe even has known hyperparathyroidism from it, and then has painful plaques that are ulcerating and necrosing, and I'm seeing calcs and I'm seeing acute ischemia. Even if I don't see the calcified vessels, surely that's what's causing it, unless you can show me that there's another reason, right? What else would be causing it? So that is really the way I conceptually think about it. You can consider that for whatever you like. You again, like I said, those are the changes in the subcutaneous. You will also usually see fibrin thrombi in the vessels, often multiples. Again, sometimes you see all these findings, sometimes you don't. This case is really good because it's got everything. Another finding that is classically talked about, but I've only seen in a limited number of cases, is you get little fine calcs around the eccrine coils, which I used to say I'd never seen that in anything except for calciphylaxis, but I did see a case maybe a year or two ago of, like, I can't remember what the cause was. They had some inflammatory I can't remember if they had like a ruptured cyst, something caused fat necrosis and inflammation. And this person did have some calcs around their eccrine coils, and they clearly did not fit for calciphylaxis clinically. So occasionally you can see it, but there have been some studies that said calcs around the eccrine coils are a really specific finding for calciphylaxis. I don't see it here, but it's one of those things I usually have to go all the way to 40x and look carefully. And often, even with looking carefully, I can usually only pick it up in some cases on the von Casa stain. So if you have eccrine coils, it's a worthwhile thing to think about looking carefully there, maybe do a von Casa and look for it. It can be helpful. And then the acute ischemia sign, the dead, wiped out ghost epidermis. Sometimes it's, dramatic like this, but if it just happened, like this skin right here is not totally dead, right? It's like if you've seen Monty Python and the Holy Grail, it's like, I'm not quite dead yet. If you laughed at that, thank you. If you didn't understand, that's okay. You may consider watching that movie sometime. It's old school, but it's pretty funny. So here, the top of the epidermis is starting to die. The rest is not happy, but it's still clinging on for life. So this sign right here makes me even think. If I see this, I'm like, ooh, I wonder if we have acute ischemia that just hasn't quite killed this tissue yet. If you wouldn't have biopsied this, maybe it'd be dead in a day or two. It's on its way out. It's on its way dying, and then areas there where you can see that's full-blown complete acute ischemia. So this pattern is super important to recognize because it can be seen not only in calciphylaxis, but in DIC, any sort of coagulopathy where you have thrombosed vessels, cryoglobulinemia, really severe leukocytoclastic vasculitis where the vessels are blocked off. So all those settings. And look here, we can't see it in real clarity, but this purple stuff here is actually probably bacterial colonies, which are super infecting, secondarily growing on this dead tissue culture. I'm sorry, this is like a dead culture plate. This dead tissue is like a perfect culture medium to grow bacteria. So I think anytime I see a big necrotic ulcer, it's common to see bacteria or sometimes fungus grow on the surface, sometimes making even the thick layer, but not down deep. So to me, that tells me certainly that's superimposed surface overgrowth of skin flora or maybe candida yeast when there's yeast there. The reason that's important is because a lot of times the question is, could there be infection? So if I just see bacteria or fungus on the surface of a dead acute ischemic ulcer, I will usually mention it. I think maybe decolonization might be helpful. I don't know. But if it's only on top, it's probably not playing any causative role in what's going on. If it's down deeper, things get more complicated, right? Then it becomes a question of, is it both or one or the other and one secondary? Okay. So we've talked about that at length. I've got some examples with even better pictures online in a different video about calciphylaxis. You can go check it out on YouTube or Kiko. All right, 7.
I can do this one.
Okay.
So if I'm in low power, we can see this really deep punch biopsy. You can see something really thickened.
Yeah.
Down there. So
And-
for this,
Okay.
yeah, and then really sclerotic, thickened.
Yeah, very
So for this
sclerotic.
one, yeah, and then tons of information mixed between lymphocytes, most likely.
Yeah, hard to tell on this scan, but lymphocytes, a lot of times you'll see plasma cells in here, and you may or may not see these little guys, eosinophils, right?
Yes, yes,
So what is it then, Li Ping?
eosinophilic fasciitis.
Yeah, this is a nice, really nice example of eosinophilic fasciitis, which is something I only rarely see in practice. So this presents as a firm, woody induration. That's the term that's often used to describe it, like a firm plaque that's very hard and feels like fixed. If you try to move it, like it kind of all moves together, right? Because it's fixed to the fascia is the idea. And it's on oftentimes like on the thigh, on the leg, and it may be bilateral sometimes. And my understanding is that some cases can be painful. Is that right? Do you guys think of it as painful sometimes?
I think it can be painful.
Yeah, I think it was.
Yeah, I feel like I don't know how often, but I feel like I've read sometimes it can. Again, I've only seen a few pretty convincing cases, and this is probably the best example I've seen, honestly. I thought I had a really good recut of it, but this is even better. So the epidermis, dermis, and even the upper part of the subcutaneous is pretty normal. Then as we get down, you start seeing some thickening and sclerosis of the subcutaneous septa, right? The lobules may have a little touch of necrosis and some inflammation, but really not too bothered. The septa are getting thickened, and then here it's really thickened and very like layered sclerosis here, going all the way down from this deep sub-Q and kind of hooking up on, this is the normal fascia right here, see? The squiggly line, the ramen noodle sign, real squiggly like the instant noodles out of a package, that my fellow Ed Fulton liked to say is a good sign for dense regular connective tissue or for fibroblastic things. So that's fascia there. And so this sclerotic bands coming from the subcutis are kind of attaching and adhering to and even sometimes full thickness involvement of the fascia. So we want sclerosis of the subcutaneous septa and or fascia, and ideally we'll get some lymphocyte aggregates, often with plasma cells. And the idea that many people have, and that I think is probably true, is that this is basically like a form of deep morphea, right? So morphea is localized scleroderma that makes kind of a linear or plaque-like area, usually causes dense sclerosis of the dermis with lymphoplasmacytic infiltrate, often around the deep dermal vessels. So if you take that same kind of pattern of what you see in morphea and take it from the dermis and move it down to the subcutaneous septa and or the fascia, that's basically what you get in eosinophilic fasciitis. Now, why is it called eosinophilic fasciitis? Well, you would expect there to be eosinophils, and sometimes there are, but it don't have to be. Okay, so eos may be present, sometimes even abundant, but there are many cases that have no eos at all. Okay, so if you want, you can think, well, the collagen looks eosinophilic. If that helps you to remember it, I don't think that's why it's named that way. So I think that some of the earlier cases that were recognized had eos, but we now see cases that don't have eos. So I've seen a couple of the cases I saw actually had almost no eos. So don't expect eos to be there despite the name. It's a bit of a misnomer. Okay, you may get a little fibrin in here. You may get more inflammation in some cases. Some cases, one case I saw had less inflammation than this. Just like morphea, right? It can have more inflammation early on. Later on, it kind of burns out and it's just sclerotic collagen with less inflammation. So it's a really interesting kind of disease because it has a unique presentation and a pretty unique appearance. The important thing is obviously you got to get the right biopsy to make this diagnosis. If you just have a shave, no way. Of course, anything we're talking about here, shave biopsy, not acceptable. Even a regular, all the things today, paniculitis, I guess I should have talked about that at first. The best scenario is to get a biopsy like this, an ellipse, a wedge, an incisional biopsy. Ideally, if you can go from normal skin into the abnormal skin, and then when it gets sectioned, if you can do it longitudinally so you can see the interface from normal to abnormal, that can be really helpful in a variety of settings, particularly in paniculitis or big ulcers when you're thinking of calciphylaxis enzymes, PG, pyoderma gangrenosum, those kind of things, having this big, deep biopsy of a large piece of tissue. I understand that's not always easy to do, especially if the patient's inpatient on the floor. So a very deep punch or a telescoping, aka double punch, where you punch down as deep as you can go in the fat, snip that piece out, and then go into the same hole and punch out more fat is not perfect. It sometimes works well. Sometimes it gets kind of fragmented and it doesn't work. But I've often seen double punches get the job done. So if you're able to get an ellipse or a wedge, that's the best, especially for eosinophilic fasciitis. For other forms of paniculitis, I feel a double punch often is good enough to get the job done. But this is a disease that can be really hard to diagnose because what if you just get like that? There's a little sclerosis in the subcutis, but can I make a diagnosis for sure just on this one area with one vessel with perivascular lymphs? And this would have been a really deep biopsy already. So this is one where you might even want general surgery if you're not comfortable to go down and get you a wedge to the fascia, ideally take a little fascia with it if they can. Okay, so this is not a diagnosis that's seen or entertained very often. I mean, I only see this come up on the differential diagnosis for patients maybe a couple times a year. Okay, so it's an important disease to know about, but it is rare. Okay, and you got to get the right biopsy. You got to get deep enough. If you're not down near the fascia, you're probably going to miss the diagnostic features. And I'm going to tell you that you need to go back and sample deeper again. So go ahead and take the time to get that biopsy done the right way the first time so we can get this diagnosis. I do not know much about treatment or management of this disease, but in any case, it's a pretty interesting thing that you don't get to see a good example really often. And the last thing I'll point out before we move on is I did see a case in the past of scurvy that presented clinically as they were really worried it's eosinophilic fasciitis. The patient was an adolescent and had a very restricted diet, had dietary issues, and they were only taking in a very limited diet. And they had scurvy, but no one suspected scurvy because they had basically no hemorrhages on the skin. But a very astute resident took clinical photos that even though they weren't exciting looking, there were some abnormalities of the hairs. The hairs looked kind of corkscrew. The patient had firm indurated plaques. On imaging, they had kind of some enhancing signal and thickening of the fascia. So the idea of eosinophilic fasciitis came up because it was really painful. And it was so much pain that the person really was struggling to walk. And only because of the corkscrew hairs and then the good history about that the patient had limited dietary intake, and then some good searching by another brilliant colleague who was able to find out that in fact there have been a few cases of scurvy reported as presenting like eosinophilic fasciitis, but microscopically all I saw was a little bit of kind of maybe some sclerosis, not much, and some hemorrhage, very non-specific stuff, a little touch of fat necrosis. It just looked like nothing microscopically. It did not really look like this at all, but it clinically was presenting like this, and only with all the pieces put together did it come out to be that it was actually scurvy. So that was pretty awesome. And the epidermis is over here, but I'm not going to risk like rotating it in case it freaks out on me. So what's going on here? Nothing too exciting, huh?
I can take this one.
Okay.
Oh, I mean, this just looks like, I mean, there's a cystic space in the center. It kind of looks like there's some keratin flakes there.
Yeah.
But this might be one that's kind of a distractor, because it looks more like just a ruptured cyst or ruptured folliculitis. It's pretty huge, so I'm
Yeah.
cyst.
Very good. Yeah, ruptured cyst and ruptured follicle, ruptured folliculitis, all this furuncle, all the same spectrum of microscopic findings, but usually, you know, follicles can be smaller and superficial, cyst big and deep. Sometimes I can't tell, but it's the same spectrum of things that's happening. It is actually an important thing to recognize because, yeah, we see these regularly and they take it out as it's a cyst. We see it's a bunch of granulation tissue, fat necrosis here, scar and kind of young scar and granulation tissue. And then there's fat necrosis. There's, you know, more dense fibrosis. There's some giant cells in here, lymphs, plasma cells, sometimes eosinophils, neutrophils. Then you get big, nice granulomas, and then the granulomas are kind of almost palisaded around a big cystic space. And then in the cystic space, we got keratin debris. So the mixture of findings is not very specific. The key is finding the keratin flakes, which sometimes can be very rare and focal. And there's times I'll go occasionally, usually you can see them on H&E if you just look carefully. I've occasionally even done like a keratin stain because I thought something might be keratin, but I wasn't sure. And I wanted to make sure because the differential was, you know, infection or something else. So that actually comes up a lot where if I take away all the keratin here and I put this granulation tissue, granulomas, especially if there's a lot of neutrophils, then our biggest differential is infection, like, right? Like fungal infection or an abscess or something. Because I mean, look, there's, you know, giant cells, granuloma, and neutrophils. And we said granulomas and neutrophils infection until you prove otherwise. So yeah, there could still be coexistent infection here, but a lot of times we see abscess type changes around the ruptured cyst, probably just secondary to the keratin. The body has a real brisk inflammatory response to keratin. You know, there may be sometimes where there is a secondary little bit of infection because cysts and follicles get bacteria in them from the flora of the skin. It ruptures, it infects the you know, that area, but it's probably been cured by the removal. So I don't always, if I see keratin debris, I don't routinely usually do bug stains. I may sometimes, if it's really brisk, like abscess, I may say there's associated abscess. In a comment, say there's abscess. It could be coexistent infection. If it persists, you may want to repeat biopsy for cultures. So other people may disagree and may always do bug stains. I feel like that's overkill for me, but I wouldn't say it's wrong to do. I think different people have different thresholds. Depends on the clinical scenario, right? So finding the keratin is helpful. Finding a cyst wall is helpful. So yeah, here no big deal. But there are times where like the differential is this versus paniculitis or something else. So finding that keratin debris really can solve the case. Saying, oh, I've got an explanation for why this super robust inflammation and fat necrosis is going on. Because otherwise, over here you might say, yeah, this could be some inflammatory paniculitis or something else. Okay, but here just the ruptured epidermal inclusion cyst, aka epidermoid cyst, aka follicular infundibular cyst. Now, how do I know? I can't see the lining. Just because that loose flaky keratin pattern that's the kind of cyst that grows that kind of keratin. So am I 100% sure it's that type of cyst? No, but it probably is. It's probably the follicular infundibular or epidermoid cyst that's making it because of the keratin flakes. All right.
Okay, I can do this one.
Okay.
So seeing kind of mixed inflammation, looks like almost like little cannonballs in the lobules of the fat, and then some septal inflammation and fibrosis as well. But with the organization of all the inflam, thinking more of like a nodular vasculitis.
Good. Yeah, I think this is one of these things that I have thought of multiple times. I've raised it in the differential diagnosis in my report multiple times. I don't know that I've ever seen a bona fide definitive example of this in real life. So nodular vasculitis, which is also known as erythema induratum. So the question is, well, nodular vasculitis, where's the vasculitis? So that's the problem with this is sometimes you see it with vascular damage and vasculitis. Probably this is kind of a bit of that right here. This probably is a dead, damaged vessel. You can see the red cells in the middle, and there's necrosis with some neutrophils around the obliterated wall of the vessel surrounded by a granuloma. Big, nice granuloma with a necrotizing center. So really, though, it really depends if you think that's a vessel or not. You could call this a necrotizing granuloma, or you could say maybe it's granulomatous necrotizing vasculitis. It's sometimes hard to decide which thing is the primary thing here. So the way I think of it is if I see granulomatous stuff with a lot of necrosis and anything that suggests possible vascular damage, number one, I want to make sure it's not infectious, right? We got granulomas with necrosis, infection. We got to rule that out. Number two, I want to think of weird vasculitis, and that would include nodular vasculitis, like erythema induratum, the other name for that. And it would also include things like granulomatosis with polyangiitis, formerly known as Wegener's, right? And an ANCA-associated vasculitis, and some other weird and unusual things too can come in the differential. If you had, here we have nice necrosis and some neutrophils, but some areas here we've got very tight, non-necrotic, tuberculoid or sarcoidal type granulomas that have very minimal inflammation. They're naked, tight granulomas. Those to me look perfect for sarcoidosis, right? And we can have a form of sarcoidosis that involves a subcutis called Derrier-Roussy, which is subcutaneous sarcoid. And also I've seen beautiful sarcoidal granulomas also in foreign body granulomas sometimes. So polarize this to make sure there's no foreign material. Do bug stains to make sure it's not infection. If you've ruled all that out, then I'm going to tell you, go do a workup for systemic vasculitis, including ANCA, and maybe consider testing for what? What causes nodular vasculitis, erythema induratum? What is the cause of it, or what is it, what's making this happen?
It's usually TB.
Right, but TB where? Not here, right? TB somewhere else in the body, which is weird. So this is considered or thought to be a so-called tuberculid. And these are always kind of blew my mind. The idea being that this is a process that's driven by tuberculosis infection elsewhere in the body. And I guess the idea is that somehow those antigens from the TB bacteria circulate in the body and for some reason cause inflammatory reaction elsewhere in the body where the organisms are not actually there. So it's some immune response driven by that. And we can see other id type reactions, right? Like the classic id being like this spongiotic and perivascular and edematous eruption that you get where you have fungus on your feet, and then you get this inflammatory eruption on the arms or elsewhere that are driven by the immune response related to the fungal infection on the feet. That blew my mind when I first heard about id eruption or id reaction. And tuberculids blow my mind too. So it's the immune system is like revved up and turned on by the TB elsewhere, and it begins making granulomas plus minus vascular damage elsewhere in the body. So telling them to, check the patient with maybe quantiferon gold or some other similar test to see if they might have lab signs of active TB, potentially do a chest x-ray if clinically appropriate, all those things. So the reason I'm bringing all this up, these paniculitis cases, we didn't really delve into the philosophy of it, but they're hard. I find these often really challenging because they don't always neatly fit into boxes, and oftentimes the differential is broad, and oftentimes I'm left with saying, well, I don't see infection, but you might want to culture to make sure it's not infection, and you might want to do XYZ on a laundry list of different things to try to figure out the case, which is kind of frustrating and unsatisfying because we often don't find out what the actual answer is unless someone goes back and gives me follow-up. All right. So anyway, I think it's an important thing to think of these necrotizing, or some people say caseating granulomas. That's a bit of a misnomer. It's more of a gross description, but in any case, necrotizing granulomas. You have to exclude infection here, but if you've ruled out infection here, I would still want cultures done here. Then I would say do quantiferon and check the patient for TB, and also check them for ANCA while you're at it, probably. Because ANCA, one of my mentors, Phil Cagle, who's a lung pathologist, he told me once that, I think there was a case that he had been using in a study set as like a good example of granulomatosis with polyangiitis Wegener's, and the patient ended up later, they found out they had TB, or else it was vice versa. But he was bringing up and I love that he told me that story, because the point is that even for an experienced lung pathologist, TB and Wegener's can look so similar sometimes that you could really confuse them. So I thought that was a really important pearl that I've always carried with me, that disease can, sometimes they have vasculitis, sometimes they don't. Sometimes you get a lot of granulomas, sometimes not as much. So it's important to keep that in mind. Okay, great. Next case. Oh, and the last thing I did want to say, I like that you pointed out that erythema induratum it has both lobule, the fat lobules are involved, and there's septal involvement. So it's classically, people often like to split panniculitis into, is it septal or is it lobular or both? And I think induratum comes into the both category, where it's both the septa are widened and inflamed and thickened and fibrotic, and there's lobular involvement with the granulomas. Whereas erythema nodosum is the classic septal only. But honestly, I would say erythema nodosum, that's really helpful because it is usually septal predominant. Pretty much all the other panniculitis are kind of a mixed bag, and I don't personally find the lobular versus septal to be really that helpful, with the exception of E nodosum, which really is septal. But everything else, I feel like it doesn't really help me that much. If you find it helpful for you, though, use that, okay? All right, now 10.
I can jump in on this one. So I think this one you can tell really is a septal.
Yes, good. How timely.
So this is erythema nodosum.
Yeah, this is like perfect classic erythema nodosum, right? And again, the beautiful biopsy went all the way down and got not just a little bit of the fat, but deep fat. And see, this is a good example. Like if we had even some fat here, I could say there's a little septal thickening. There's a little bit of lymphocytic infiltrate, even though it gets into the lobule a little, which is common to see a little lobular involvement, but it is definitely accentuated near or in the septa, right? I think we can clearly see from low power that, yeah, it's okay to have septal inflammation. I'm sorry, a lobule meaning in the middle of the fat again. If you're just tuning in online, in the middle of the fat being involved, there's most of the fat lobule here has relatively normal-ish fat, maybe a touch of fat necrosis, touch of atrophy, a little bit of lymphocytic infiltrate, but it's relatively uninvolved, whereas the septa is much more involved. But yeah, if we didn't get very deep, I could maybe suggest if you wanted E nodosum clinically, I could say, yeah, it might be, but it'd be hard to say for sure. Whereas if you get deep into the fat, either through an ellipse or a double punch, it's easier to be like slam dunk. This is E nodosum. Great example. The dermis is often normal or minimal, maybe a little bit of perivascular inflammation. So you guys know erythema nodosum is kind of the classic, stereotypical, probably most common form of panniculitis we see, or one of the more common forms, one or multiple painful erythematous nodules, often arising kind of suddenly, often on the legs of young adults. Seems to be, a little bit more common in women, maybe associated with oral contraceptive use. Those are kind of some of the board's buzzwords, right? So we can see it. It depends what we see here. It depends on the stage of it. In the kind of earlier stage, you get a lot more inflammation. Lymphocytes, maybe plasma cells, maybe eos, sometimes neutrophils even. So there can be cases where there's a decent bit of neutrophils and you can think about infection. You often get a lot of hemorrhage. You begin to get kind of granulation tissue with juicy myofibroblasts, kind of stellate, almost fasciitis-like looking, like nodular fasciitis-like looking areas with myxoid change. Then you may begin to see granulomas with giant cells. And there were some, maybe it was on the other slide, hold on. Here. And these granulomas sometimes have this spiky kind of radial arrangement that's called like the Meischer's radial granuloma. I'd see that in a subset of cases. I don't feel like you have to have it. If you have this, I don't know if this exactly qualifies for one, but I think this kind of falls into the spectrum of the Meischer type granulomas. But I feel like you get vague little clusters of giant cells and granuloma, often with foam cells. Again, mixture of inflammatory stuff, including neutrophils sometimes. And then as the disease progresses, you get more of that young kind of fasciitis-like granulation tissue stuff that you see begins to kind of mature and turn into more and more collagenized sclerotic scar. And eventually the inflammation burns out and you get scarred bands that are left over. So it depends. The earlier stage can be much more inflammatory. Here's another one of those kind of vague granulomas right here. So this is really good for erythema nodosum. Okay, so that's a pretty nice example. But you may see fibrin, you may see neutrophils, you may see nuclear dust, you may see some vasculitis and stuff that looks kind of vasculitic or vascular damage. So I've seen those kind of changes in early erythema nodosum. So definitely think about other stuff. Think about, ankavasculitis and other things if I'm starting to see a lot of vascular damage. But if it otherwise fits well for erythema nodosum clinically, and I just see a little vascular damage microscopically, I think that's still totally fine for erythema nodosum. But I do want to start thinking about other things if I start seeing a lot of neutrophils and a lot of vascular damage, okay? But it's a really great example of nodosum. Okay, 11.
I can take this one. as it's coming into focus, I can just see tons and tons of inflammation around what kind of appear to be 3, 4. They're still out of focus.
Yeah, I know.
Sinus
There we go.
tract.
Yeah. Okay. Good.
And it looks like it is involving most of the dermis.
Yeah.
And
And
this is a big,
even down to the
this is
sub-Q.
almost like an excision.
Yeah.
Yep, all the way down to the fat, and that tract keeps going down deep. So I'm still struggling to see cell types, but it does look like a dirty inflammatory mix.
Yeah. Neutrophils. Yeah. A little of everything, right? Newts, lymphs, plasma cells, often EOs, red cell extravasation, all of it. Throw it all together. It's the kitchen sink.
So one other thing I always wonder is, are plasma cells more disease specific or site specific? Because a lot of diseases we see with plasma cells are specific for sites.
It's a great point.
Getting to the diagnosis at hand, this is hidradenitis suppurativa.
Yeah.
Or some kind of follicular triad kind of disease.
Yeah, exactly. So you can learn a couple diseases for the price of one here. This is like a real classic example of hidradenitis suppurativa, HS, which is usually in the groin or the axilla or under the breast fold sites, and has multiple draining sinus tracts. Is really morbid, terrible disease, as you guys all know. What you see microscopically can vary greatly from case to case, and the clinical is dramatically important. If you just show me this and said rule out cyst, I'd say cool, inflamed ruptured cyst. No problem. If you told me I want hidradenitis suppurativa, I'd say consistent with hidradenitis suppurativa. If you told me this was a draining tract in the superior gluteal cleft, and you wanted pilonidal sinus or cyst or tract or pilonidal disease, as I call it, I would say consistent with pilonidal disease. So all this pattern can fit with ruptured cyst, hidradenitis, pilonidal. All of those can show an overlapping and sometimes identical mixture of features. And those features include actual cyst wall, often inflamed, often edematous and spongy, plus minus rupture, plus minus keratin debris, often with keratin granulomas, often with really brisk inflammation that's rich in lymphs and plasma cells. You may or may not have neutrophil abscesses. You often have a lot of granulation tissue with edema. Sometimes you'll just see granulation tissue that has pseudocystic edema in the middle with no cyst lining at all. Sometimes it'll just be mostly scarred down with features of like a burnt out ruptured cyst. Any of those combo of features in the clinical setting of hidradenitis, I will say is consistent with hidradenitis. Or if you wanted it just a solitary lesion and it's only a ruptured cyst clinically, then it's fine for a ruptured cyst. And the same thing, pilonidal, which will classically have a mixture of these things plus naked hair shafts, over half the cases I see don't have naked hair shafts. So they may have any of this combo. So all of those things could be hidradenitis or pilonidal or ruptured cyst. All right, good job. And then this is case 12. And this is one that's best from low power.
I can take it because it's similar to the last one I did. Also, I feel like it's a little bit smaller cells, but you have this nice walled off, like fibrous capsule.
Yeah.
So this would likely be an encapsulated fat necrosis, like maybe in the breast area from trauma or something like that.
Yeah, exactly. This is perfect. And here, look, this is very much like your last case. Not nearly as severe, but these little lobules are a little bit atrophic. Not dramatically signet ring, but they're shrinking. The vessels are more, the cellularity is more. So this is a little more chronic, probably from this nodule down here. This probably happened acutely, right? Like you said, I think that most of these, this is called encapsulated fat necrosis or nodular encapsulated fat necrosis, or sometimes mobile encapsulated fat necrosis, because they often can have like a little tract that's split apart in the sub-Q. And the nodule, you can like push it around. If you look up videos online, it's crazy. Like it's like a marble under the skin that the patient can like move back and forth. And it may be present for years because what happened is probably they got bumped against something and the fat died. And instead of getting inflamed and necrosed, it just got suddenly all wiped out and necrosed, and then the body walled it off. So because my theory is, at least because it walls off with this sclerotic scar capsule, it never really gets inflamed. the fat never breaks down. It just stays there dead and mummified without any inflammation or breakdown. Sometimes it calcifies. Sometimes you get a little inflammation. Sometimes it can liquefy. And once they cut it open grossly, it will drain out. And all you'll see is this sclerotic shell with only when you look close and you see some little foam cells around the outside or little tiny atrophic fat cells. That's when you know, oh, I bet this is one of those liquefied examples of nodular fat necrosis. Some people call these mobile lipoma. They're not lipomas. They're nodules of dead fat that are not actually a lipoma, but it doesn't matter. But they're not neoplastic. I do see these in the extremities a lot, but also occasionally in the breast, like you said, and I do think most cases are probably from trauma. So benign and beautiful, and they usually kind of pop out whole and intact like that. 13. Okay. Got 3 pieces here. They all kind of similar look. Let's do this one.
So for this one, starting at the top too can sometimes help you as well, because you see like a little bit of almost stasis changes.
Good, yeah.
And that can kind of help clue you into sight in terms of, oh, you might be on the leg.
Good.
So that helps a lot with this panniculitis. And then when you go down deeper, you can start to see it's more of like a lobular process. And what I tend to look for is kind of like the lipomembranous changes, like kind of like the feathery bits. I think that really helps me to kind of say that this is lipodermatosclerosis.
Yeah, lipodermatosclerosis. This is the classic textbook exam question and finding. This frilly, fern-like, frond-like stuff that almost looks like a weird, or a weird worm. I think that sometimes if you're having a bad day, in the past people didn't always know, and they wondered if these were like helminths or something. I think early on, until people figured out what this is the fat cell died, and the membranes kind of folded into this complex pattern. And so these are the dead fat cell membranes that are all infolding and give this really pretty pattern called the arabesque pattern, or the membranous lipodystrophy pattern, whatever name you like for it. That pattern is classic for lipodermatosclerosis. In real life, I do see it sometimes in fat necrosis from other settings. In addition to that, like you said, we usually have stasis change up top because this is thought to be a severe form of stasis that gives you these like dense sclerotic kind of firm areas of atrophy on the lower legs, whereas the upper like calf is more normal, and then down at the distal end of the lower leg is really sclerosed and shrunken down. So the inverted champagne bottle appearance clinically. I don't know why, why does this happen? So much sclerosis and damage to the fat down here, and yet this person, they have stasis, but I mean, I see stasis that's way worse than this all the time, and the people don't have lipodermatosclerosis. So I don't understand why some people get this and some people don't, but the thought is that this is basically a variation of vascular stasis, venous stasis, that involves the deep dermis and subcutis. But the findings often maybe really throughout the dermis and subcutis, but here it was more subcutaneous predominant in this case. So then you will also have fat necrosis, fat atrophy, dense sclerotic hyalinized collagen filling up the septa, and in the fat here, look at the calcs. So if what if calciphylaxis were in the differential? Then you might have some trouble, right? Because some of these things are the calcs we can see in calciphylaxis, but again, you can see them in other settings too. Okay, so varying amounts of calcification are often present. This case actually has a nodule of ossification, bone. This is actually a whole bone nodule that's mostly chunked out. And you will have varying amounts of inflammation, often lymphs and plasma cells. And you may actually get cystic spaces where the fat liquefies, and you get like fat necrosis that has all washed out and just left a little foamy histiocytes lining around the edge of the cystic space. So all of that mixture of stuff can be seen in lipodermatosclerosis, which again is like a severe form of stasis that causes panniculitis and fat necrosis. And this is a great example of something we thankfully rarely see anymore.
You just have looks like fat tissue with some sclerotic septae.
Yep.
But the real thing is something like, not really like the fat because they are perfectly round. It looks like maybe mixed with this granuloma, reactive changes. So could be something implants and leaking out, this foreign material,
Yeah.
some refractile.
Yes. Yeah, it's hard to see on a digital slide. This is better with glass because you can flip the condenser to see this totally clear stuff has like a three-dimensionality to it. It's like it's something that's actually there that's sticking up a little bit from the tissue and is totally clear. So this is not an air bubble. This is actually stuff that's there in the sample, like you pointed out. So what is this then, Lipe?
The silicone.
Yeah, this is a silicone granuloma. So the reason I think that we don't see it as much anymore is because the silicone breast implants that have been used have changed a lot over time. And the newer ones, there's both silicone and saline filled, right? But the silicone ones now have the silicone is like somehow more held together as like a mass. It's like I've seen videos where they cut into it and it can like bulge out, but it doesn't like leak out. It's not like liquid silicone. It's like a gelatinous, like, jiggly solid mass, even if the capsule is cut. So the point is that even if an implant ruptures, because implants do have a lifespan to them, is my understanding, even if it ruptures, the silicone is not likely to leak to any significant extent. But in the past, in earlier implants, if an implant ruptured, the silicone leaked out and it caused extensive, really robust granulomatous response, which is basically what we got is just this extensive foreign body granuloma. But because the silicone is clear and because some of it kind of leaks out as we process the tissue, it gives you the impression of fat necrosis. There also is actual fat necrosis here, but these big, huge round spaces, they're like, I guess they could be like a totally like cystic area of lipid, but they basically look like giant fat cells, way, way too big to be individual fat cells, right? And then the key is looking closer and seeing the clear refractile kind of plate-like. It reminds me of like shards of glass, or like glass looks different than this microscopically actually, but it makes me think of like bits of like clear plastic or plexiglass or something. I don't know what works for you, but I the few times I saw this when I was in training mostly, that's what it made me think of. These like, so anytime I see this pattern of big cystic clear spaces in a foreign body granuloma, I go looking for clear stuff and also polarized. My recollection is that silicone will not actually polarize. Silica, I think, can, like silicate, like sand type material, but the silicone used for implants, I don't think polarizes, but you can look and see that it's refractile. And multinucleated foreign body giant cells, often with bubbly little vacuoles. And if you look around, you will find usually, if you want to look and see good asteroid bodies, the best time to see asteroid bodies is not in sarcoidosis, despite the teaching that everyone gets in med school. The best asteroid bodies I see are actually in the setting of foreign body granulomas. That's not a very good one, but you can look. I saw one in here yesterday, but I can't remember where it was on the slide. But this is the prime hunting grounds for asteroid bodies is foreign body granulomas. I don't think I've ever actually seen a real case of sarcoid that had an asteroid body. Then again, I see foreign body granulomas like 100 or maybe 1,000 times more often than I see real bona fide sarcoidosis. That, I promise, that's a little asteroid body. She's not very good to see on this scan. But anyway, just so you know, asteroid bodies, I've got some pictures and or a video about that online you can watch if you want to see a real perfect one. Last case. 15. We're getting there.
And try to do this one, Dr. Gardner.
Okay, you can hallucinate through the pixelation here. There we go.
From low power, it seems like there's this really dense inflammatory infiltrate that seems to be just hugging around the lobules of the fat. The septae look somewhat involved as well.
Yeah.
And at medium power, it almost looks like these cells are highly pleomorphic, or there's some space in between. It's not as dark as I would think if it was just pure lymphocytes. And then at higher power, we see this sort of rimming effect around the fat globules, and I don't really see much fat necrosis, and I don't really see arabesque patterns. I don't really see hyalinization. And I think if you look at these lymphocytes, they're really pleomorphic and atypical. Some of them seem to be just strangling the individual lobules.
Yeah. Each individual adipocyte, right, is like wrapped by these hyperchromatic atypical lymphocytes. Right. Very good. So what is the diagnosis here?
is the subcutaneous paniculitis, like T-cell lymphoma.
That's right. So very good. So this is subcutaneous paniculitis like T-cell lymphoma or subcutaneous paniculitic T-cell lymphoma. And it is an important pattern to recognize. We talked about earlier in the video, this is a pattern that can overlap pretty closely sometimes with lupus profundus or lupus paniculitis. And in some patients that have subcutaneous paniculitic alpha beta T-cell lymphoma, they actually have actual lupus and also have the lymphoma. So it becomes a little bit of a complicated problem sometimes to sort this out. And I will read you an excerpt from this really great book in a minute about how to sort this out. But the classic findings, like you said, you have a dense lymphocyte infiltrate, and ideally you like to see atypical lymphocytes. I have a hard time, unless the lymphocytes are dramatically atypical, I often have a hard time determining lymphocyte atypia because I think it's kind of subtle. But I do think that even for me, who I think admittedly I struggle with this sometimes, these look really hyperchromatic. They look very dark and big, right? And then, like you said, they are rimming. This is the classic finding. They are rimming and wrapping around individual fat cells, are totally encased in these atypical lymphocytes. So that rimming of atypical hyperchromatic lymphs around individual fat cells is the classic buzzword finding for subcutaneous paniculitis like T-cell lymphoma. You may also have cells, like this might be one, that are like a histiocyte with little fragments of karyorectic debris in them that are called beanbag cells. So you often have karyorexis and nuclear debris, and sometimes the histiocytes will like eat that debris up, and you'll see little fragments inside a histiocyte. I don't know if that's the best example, but that's kind of like giving me that feeling. It gives beanbag cell, or it's giving beanbag cell, as I think maybe the kids would say. Maybe that's what like the gen alphas, when they're Dermpaths, that's what they'll say. Or they'll be like, it's giving AI, please do the job for me. I don't know. We'll see what the future holds. Sorry, if you're Gen Alpha watching this, I apologize. I'm old. Okay. I'm an elder millennial. And then, okay, so that's the classic finding there. And then I feel like morphology-wise, the things that help me sort this out from lupus paniculitis, although in real life, I certainly struggle with this, and I usually will show my colleague, Dr. Junkins Hopkins, who's much more knowledgeable about hematopathology of the skin than I am. But things that I find helpful, if I see more of that fat necrosis with really bright pink red fibrin and hemorrhage, fibrin, fibrinoid necrosis, wiping out the lobules of fat, I think of lupus paniculitis more than paniculitic T-cell lymphoma. If I see lymphoid aggregates with germinal center formation, lupus paniculitis. If we have the dermis and have features of lupus there, that makes me think of lupus paniculitis. Although, like I said, people with lupus can also get the T-cell lymphoma. So, and then if I see more atypia and obvious rimming of the fat cells, then I think more of paniculitic T-cell lymphoma rather than lupus paniculitis. But in real life, it can be challenging. And so this is a great book. This is called Diagnosis of Cutaneous Lymphoid Infiltrates by Antonio Subtil. And Tony Subtil is a really great educator. I heard him speak, and it was like, oh, I could hear like a choir of angels singing, because I was like, I think I can understand this. He just has a really great way of simplifying things. And his book, I'm not paid anything to advertise it. They did give me a free copy years ago to evaluate, but I think I actually gave that away to my residents and bought another one. So in any case, I just think it's a great book. So you can check it out. It's got great differentials and how to sort out mimics from each other. So it's a thin book, and it's just packed full of info. So I just love it. So here's what he said. Lupus, I'm just going to read it as a quote. Lupus erythematosus paniculitis and subcutaneous paniculitis like T-cell lymphoma may demonstrate significant clinical and histopathologic overlap. In addition, a significant subset of patients with paniculitis like T-cell lymphoma have a history of autoimmune disease, particularly lupus. And so the differential is challenging, right? So he said a prominent component of CD20 positive B cells, often forming CD21 positive lymphoid follicles, plasma cells, highlighted by CD79A and CD138, and plasmacytoid dendritic cells, highlighted by CD123 immunostain, as well as the presence of that hyalinized fat necrosis, that fibrin-rich fat necrosis. Those things would favor lupus paniculitis over paniculitic T-cell lymphoma. And then the things that would favor paniculitic T-cell lymphoma are lymphocyte atypia, adipocyte rimming by cytotoxic alpha-beta T cells, which are usually going to be positive for beta F1, CD3, and the CD8, and TIA1, and then they'll be negative for CD4 and CD56. Okay, so those are the things that will help you for paniculitic alpha beta T cell lymphoma. The other important differential for this is gamma delta T cell lymphoma, which in the past was kind of lumped together with paniculitic T cell lymphoma, but then people realized it behaves very differently. Gamma delta lymphoma is much more aggressive and oftentimes fatal, whereas paniculitis like T cell lymphoma alpha beta type is actually very indolent and has an excellent prognosis. So right around the time I was starting training was when people were starting to realize, just before I was in fellowship, people were starting to realize, hey, these are two different diseases, but their appearance on H&E in the fat can look, to my eye, almost identical. Maybe Dr. Junkins Hopkins can tell you some subtle differences, but alpha beta and gamma delta in the fat look very similar, but the staining pattern is different. I believe that the gamma delta is going to be CD56 positive, and I think it's 4 and 8 double negative, if I recall. I should have had that pulled up. Yes, here it's right here, next chapter. It's going to be usually CD3 positive T cells that are negative for CD5, negative for 4, plus or minus for CD8, and then CD56 positive beta F1 negative. So you can use immunostains to sort out this indolent alpha beta paniculitis like T cell from gamma delta. And we no longer call gamma delta paniculitis, like, even though it looks just like this, because we don't want any confusion with this. We call that cutaneous gamma delta T cell lymphoma, at least my understanding as of the time of this. I'm sure that the hematopathologist will change the name in the future, because, you know, names evolve, and hemapath is a complicated and rapidly evolving field. The other thing, I actually got to interview Tony Subtil. That interview is on the American Society of Dermatopathology YouTube channel. So if you want to go see that, I asked him some questions of things I struggle with. And one of the things I asked him was, how do you sort this out from gamma delta? And my recollection of what he told me is that gamma delta usually involves all levels of the skin. It involves the subcutis and the dermis, and often the epidermis with epidermotropism, whereas alpha beta paniculitis is usually just in the subcutis. So I found that helpful. Now, in a case like this, it's not going to help us because we only have fat, right? We don't have any skin to look at, but that's often, gamma delta often has overlying skin involvement, whereas alpha beta doesn't. But of course, with those immunostains and the help of your hemopath experienced colleagues, hopefully we can sort it out, because there is a significant difference in prognosis there. All right, so I took 15 cases and I still managed to go 10 minutes overtime. If nothing else, I'm consistent, right? And it's been a pleasure, guys. Thank you for joining us today online and watching. And for my residents and fellows, have a great weekend.